Hi everybody, welcome to another new episode of the General CCFP 105 Topics podcast. We're talking trauma. I am still Caleb Dusdahl, and I'm joined today by the authors of this episode. Veronica Oczkowski and also Andrea Brabant, who you've heard from before.
Hey Caleb, glad to be here. Special shout out to Dr. Matt Strickland, trauma surgeon extraordinaire at the Royal Alexandra Hospital in Edmonton, who kindly reviewed this episode for us.
No further ado, let's get into it.
According to the World Health Organization and the Centers for Disease Control, more than 9 people die every minute from injuries or violence. A total of 5.8 million people of all ages and economic groups die every year from unintentional injuries and violence. The burden of injury accounts for 18% of the world's total diseases. Motor vehicle crashes alone cause more than 1 million deaths annually and an estimated 20 million to 50 million significant injuries. They are the leading cause of death due to injury worldwide.
And unfortunately, they're very common, so we need to get comfortable with our approach. The goal today is in no way completely exhaustive, but we did our best to prepare an overview that'll help you cover all of the CCFP objectives. So get ready, it's robust, it's big, but buckle up.
Before we dive into our approach to the trauma patient, let's quickly touch on our approach to trauma situations and chat a little about triage systems.
Objective 3. When faced with several trauma patients, triage according to resources and treatment priorities.
Regardless of whether this is pre-hospital field triage or ED triage, the goal is to treat critical patients who have the greatest chance of survival with the least expenditure of time and resources.
And there's so many different systems out there, and none of them are perfect. It's going to depend on your center and what you like. So practically, if you think you're going to be doing some EM work, you need to connect with your local groups to see what system they plan on using. Or if they don't have it, make a plan before this all happens.
Commonly used system is the SALT triage. It stands for Sort, Assess, Life-Saving Interventions, Treatment, or Transport. Simply put, patients are placed into 5 different categories to help decide who to treat and in which order.
Category 1 is right now. These are life-threatening and they need you.
Category 2 is delayed. These injuries require treatment within 6 hours, but are not immediately life-threatening.
Category 3, green. It's minimal injury. These are the walking wounded or people who can walk their way over to the section for category 3.
Category 4 is the expectant. Patients in this category have severe injuries that are unlikely, unfortunately, to survive in the context of available resources.
And even more than that, category 5 is black. It means they're dead. Don't waste any resources on them. Focus on the people who might stand a chance.
You guys can check out the show notes for good visual of this triage system.
And keep in mind, there's a bunch of factors that affect any triaging. The big ones to consider are the amount of personnel available, their expertise, the medical resources, and especially important in these big trauma injuries, if you have access to a surgeon and or an OR.
Okay, now we are ready to start reviewing our general approach to a trauma patient. Caleb, let's say you get a call and you're working in your local ED stating there's a trauma patient en route with an ETA of 15 minutes. What's the first thing that your mind jumps to after, crap?
Well, the crap lasts a long time, but you can always fall back on ABCDE. Objective 1. Assess and stabilize trauma patients with an organized approach, anticipating complications in a timely fashion using primary and secondary surveys.
Our systematic approach to a trauma patient starts with the primary survey, also known as the ABCDE approach. The purpose of the primary survey is to identify immediately life-threatening injuries and address them appropriately.
It's important, so if we lost you already, listen. If you were distracted before, stop being distracted. The clinical conditions in trauma can shift rapidly, so any decline in patient status or change in their status in general means repeating the primary survey from the beginning. You want to identify any changes in their status that need immediate intervention.
A useful approach to consider is the ABCDE mnemonic, which allows a systematic approach. That being said, as we review it, keep in mind things can happen simultaneously and out of sequence if the situation demands it. Using our simple mnemonic ABCDE, it will guide us through the steps of our primary survey.
Let's do it!
A. A stands for airway maintenance and cervical spine protection.
We know we start with A. We know the airway is important, but in trauma, you should always also be thinking of cervical spine protection when you're looking at A.
Consider if your patient requires spinal motion restriction, or SMR. In other words, if they should be placed in a cervical collar. This is a commonly donned pre-hospital by our colleagues, but not always. If a patient arrives already in the SMR, ensure the collar is appropriately placed. It is good to know which collar is used by your area or ED to facilitate faster use of such devices. If there are no collars, quickly assess if one is indicated.
And the indications for that spinal immobilization following a blunt trauma follow the Canadian C-spine rule, and we'll just review it real quick here.
First one's dangerous mechanism of injury, which by far is the most common indication.
Next is acutely altered level of consciousness. Anyone under GCS 15, this is because they can't tell you if their neck hurts or if they have tingling in their hands.
Speaking of neck pain, the next one is midline neck pain.
Any focal neurosigns or symptoms, so numbness, motor weakness, that's all indications to scan their spine.
If we see an anatomic deformity of the spine.
And if there's a distracting injury, they might not notice that their neck hurts if they've got a big femur fracture or something.
Quick reminder though, a cervical collar is not itself a benign procedure. It does have risks, including the following.
Risk of aspiration. If you've never rolled somebody down to CT in a C-collar and they start vomiting, you will realize after you do that it's a big aspiration risk.
Impeded airway management. It can restrict our mouths by 25%.
Yeah, if you need to, get someone to hold the head and pull the collar off when you're intubating. Otherwise, you're going to have lots of trouble. Another risk is that it can directly compromise respiration, which I didn't realize. It can drop your FEV1 by 15%.
It can increase your intracranial pressure, which complicates to a global brain injury.
If they end up lying too long off in some corner of the ER, you can get pressure ulcerations or you can get rashes, which causes increased pain and increased chance of causing an infection.
Last but not least, it can conceal important physical exam findings, so soft tissue injuries, tracheal deviation, and that subcutaneous air finding.
Totally. That one's super important. So I would do the same thing with that. If you really have to do a full assessment, which you do, get somebody to secure the head and then open up the collar and go to town actually doing a complete exam. So the C-collar is an important tool, but you have to make sure that A, it's indicated, and keep in mind those contraindications that we talked about. There are other contraindications, things like penetrating trauma and ankylosing spondylitis. There are documented neurological deterioration and even death for people that were put in a cervical collar when they have ankylosing spondylitis. No bueno.
Once that's settled, we quickly move on to our true A, which is airway.
Airway needs to be rapidly assessed. You're checking for patency and protection in all your trauma patients. Even if they don't seem quite severe, go through your steps. This can be simple in an awake patient. Just ask them to tell you their name, listen for stridor or dysphonia, and ask them what occurred during the incident. You'll figure out if their airway is working or not.
It is also important to identify any significant facial trauma or burn injuries, which puts the airway at risk for compromise. This includes assessing the risk of inhalation injury. You can also search and remove any foreign bodies.
That being said, it's no longer recommended to do a blind sweep in the mouth, as you might push the tongue back and further obstruct the airway. So if you don't see anything when you look, keep your fingers out.
An altered level of consciousness can also render a patient unable to protect their own airway. You may have heard of the trauma rule of GCS less than 8, intubate. An obtunded patient is at risk for airway compromise.
So what if we decide that, yeah, the airway is at risk? What now?
Well, this kind of spills into objective number 4.
Objective 4. In trauma patients, secure the airway appropriately.
When required, airway management can be broken down into 3 categories: basic, temporizing, and definitive.
In basic town, we support the airway, doing simple maneuvers to try and improve both oxygenation and ventilation. These are
a jaw thrust. This might be the most important initial procedure for an obtunded patient.
As a note, chin lifts, which we'll talk about later, are not commonly used in blunt trauma patients because that can move your cervical spine and cause issues that we don't want to cause. So just put your thumbs on the zygoma, your first and second digits on the back of the mandible, and pull it forward.
Supplemental oxygen is often administered to all our patients as well.
And if your basic maneuvers aren't sufficient, then temporizing measures can be considered. These are the next move on our line. They're used until definitive airway can be established, and in temporizing measures, we include things like NPAs, OPAs, and LMAs.
An NPA, or nasopharyngeal airway, is generally used for patients with an intact cough and gag reflex. There are, however, contraindicated if there is a significant facial trauma or suspicion of basilar skull fractures, as there is a risk of displacement, it ending up where you definitely don't want it.
An OPA, oropharyngeal airway, is also a pretty good adjunct. They're reserved for unresponsive folks with no cough or gag reflex, because if you put it in and they have a gag reflex, you've just caused vomiting and caused yourself problems you don't need.
Finally, we have the LMAs, or laryngeal mask airways. These are a supraglottic airway device which can be used as a temporary measure to maintain an open airway. It is important to note they are not considered definitive, and patients remain at risk for aspiration of gastric content or blood.
And now it's the rock star move that everyone loves, but keep in mind LMAs are great. Keep them in your back pocket. Sometimes they're the best move that you can do. The real only failure that they might have is you can't positive pressure ventilate like you need to. Nonetheless, if you're on the move to definitive airways, this is basically placement of an endotracheal tube with the cuff inflated below the vocal cords. Often for obtunded or severely injured patients, it's the preferable way to secure the airway, and definitive airways allow for oxygenation and ventilation in addition to blocking any aspiration events.
ETT placement or intubation is typically done via a rapid sequence induction, or RSI. We won't go into details here, but briefly, this is a method that allows for quick sedation and temporary paralysis of patients at high risk for aspiration, which in our case is all our trauma patients, so they can be intubated.
What if you try and get in the tube and it's not happening? You just can't do it.
Well, we've already mentioned one option. An LMA is a great backup to have on hand, remembering that it is not a definitive airway, but there are also a few adjuncts that can help with difficult intubations, including using a bougie in circumstances where oral intubation is not a reasonable clinical option. For example, if significant anatomical disruption of the face or neck, or after a failed intubation, a surgical airway or emergency front of neck access (EFONA) is performed.
You mean like that thing that they do in MASH? Old. I'm so old.
Kinda. In an emergency situation, the more appropriate term is a cricothyroidotomy. This consists of making an incision on the front of the neck to create an opening in the cricothyroid membrane. A smaller ETT tube, 5 to 6, or if you can happen to have one around, a tracheostomy tube, is then inserted and secured.
Yeah, it's terrifying, but the most difficult part of surgical airway is said to be making the decision to do it. But it's easy once you get going into it, and you're going to save a life with it. So there's tons of resources on the internet too that point it out really well.
Is there any way of estimating which patients are more likely to have a difficult airway?
You betcha, lemon, the classic lemon.
L stands for look. We are assessing for obesity, beards, dental or facial abnormalities, trauma to the neck or face.
Like if they have a surgical airway scar, they're probably going to be a difficult airway for you. E is to evaluate using your 3-2-2 rule. If the distance between the incisors with their mouth wide open is less than 3 fingers wide, or if the distance from the front end of their chin to the hyoid bone is less than 2 fingers, or if the distance between the hyoid and the thyroid is less than 2 fingers, then you might be in for a difficult intubation. M
stands for Mallampati score. Check out our show notes for a visual, but basically the harder it is to see the patient's tonsils and uvula with their mouth wide open, the harder it will be to intubate.
O, obstruction, if there's any signs of stridor, if there's a foreign body suspected, if there's masses that compress the airway, also difficult.
And finally, N stands for neck mobility. The less extension of the upper cervical spine and flexion of the lower cervical spine, the harder it will be to place the patient into the optimal position we call the sniffing position. This is a significant restriction in trauma patients, as most of them will be on cervical precautions.
All right, quick recap. Airway management in trauma. Secure the cervical spine if it's appropriate. Assess the airway and patency. Do this by asking them some simple questions if they're awake. Think about facial traumas, burn injuries, potential obstructions, and the level of consciousness during your assessment. Rely first on your basic moves, jaw thrust and oxygen. Temporize it with an NPA, OPA, or LMA, and then if you need to, go to definitive endotracheal intubation or surgical airway.
Continuing with our ABCDE approach, we are moving on to B.
B is breathing.
Just because the patient has a patent airway doesn't mean that they are adequately ventilating. For adequate ventilation and gas exchange to occur, the lungs, chest wall, and diaphragm all have to be functioning appropriately. Therefore, each of those components will need to be assessed. To do this, we look, listen, and feel.
Look at the patient, their respirate, their oxygenation. Look for signs of increased work of breathing. So it's same as you do with kiddos, intercostal indrawing, scalene retractions, flaring their nose. Are the breaths shallow or deep? Are they fast or slow? Look at the chest for any deformities, any segments moving abnormally. Look for chest rise equal symmetrically, or look for the presence of any sucking chest wounds. If you miss that, you will be embarrassed.
Next, let's listen to our lungs. Get out your stethoscope. In the context of this primary survey, you are exclusively auscultating to assess for bilateral air entry, paying specific attention to the presence or absence of lung sounds.
And when you're auscultating, get into the armpits is what I was taught, because if you try it just at the front, you can get referred sounds from the other side and think they have breaths when they don't. Feel for a potential tracheal shift. Put your thumb and your second finger right around the trachea at the sternal notch and feel for the trachea between your fingers. Make sure it's in the middle, and then quickly move to the chest and the neck, and you're feeling for that Rice Krispie feeling of crepitus, which indicates subcutaneous air, flail segment, broken ribs, or tenderness. It's so important.
So what do we do if breathing is not adequate?
If it's life-threatening, treat it. Remember, during primary, we're looking for life-threatening things that we can reverse right now. So don't get distracted by a little bit of wheezing. In the traumatic context, this is usually things like tension pneumothorax, so you can't hear air on one side and the trachea is moving the other way. You're looking for massive hemothoraces. You're looking for significant flail chests or open pneumothoraces.
Those are those sucking chest wounds we mentioned.
I wish I had a sound of it. Provide the patient with oxygen to maintain their saturation. So a lot of patients are going to come in, they're going to be on nasal prongs. You can only really get up to 6 liters with that, although you can crank it to 15 if you want. It just probably isn't doing much. And that's probably not going to be sufficient. So for all these people in real life on your OSCEs, put them on an NRB at 15 liters per minute. You're not going to be wrong to do that for a period of time.
If you have absent breath sounds on one side and the patient is unwell, consider rapidly performing a needle decompression or placing a chest tube. A significant flail chest might require intubation to take over the patient's breathing, as they are at risk of tiring out, their lung injury evolving, and going into respiratory failure. We will discuss these diagnoses and their management further in detail in a little bit.
To summarize, be breathing. Look at the patient. Look at the respirate. Are they saturating okay? Listen for air coming in both their lungs. Feel the chest for crepitus and any obvious fractures and open sucking wounds. Address those life-threatening things. What's next?
Now we move on to C. C stands for circulation. In other words, shock.
Objective 5. In a patient with signs and symptoms of shock, recognize the shock, define the severity and type, and treat the shock.
Let's refresh our memories on the definition of shock. Shock is defined as inadequate organ and tissue perfusion and oxygenation. In other words, the metabolic demands outweigh its supply.
Generally speaking, patients in shock are going to have tachycardia, maybe some tachypnea. They'll probably have a narrower pulse pressure. This is the difference between systolic and diastolic pressures. They may have reduced cap refill and cool extremities depending on the shock. And as the shock progresses, patients can become hypotense, which is what shock's all about. They can become altered and they can stop making pee-pee.
Shock generally fits into 4 major types or categories.
Hypovolemic. They have low intravascular volume due to most commonly hemorrhage in the case of trauma, severe burns, or severe dehydration due to conditions like diarrhea or diabetic ketoacidosis. These patients need volume.
Obstructive. With obstructive shock, something is obstructing or getting in the way of the blood going into the heart or out of the heart or into and out of the great vessels. Consider diagnoses such as cardiac tamponade, tension pneumothorax, or PE, and treat accordingly. This could mean an emergent pericardiocentesis in tamponade, a needle decompression or chest tube in tension pneumo, or anticoagulation and or thrombolysis in a PE.
The next form of shock is Cardiogenic. These are cases where the heart is unable to pump the blood forward. In trauma, cardiac blunt injury tends to be the main culprit. So this category also includes myocardial ischemia, dysrhythmias, congestive heart failure, cardiomyopathies, or cardiac valve problems. This can be incidental in trauma cases, meaning it might have caused the trauma, so think of that. If there's a problem with the heart pumping adequately, treatment lies in fixing or supporting that pump.
Finally, we have distributive. This refers to systemic vasodilation leading to inadequate perfusion. This category can be further divided into septic, anaphylactic, and neurogenic shock. The circulatory system has expanded, so we want to contract it. We want to expand the volume flowing through the system. This typically includes fluids, vasopressors, antibiotics if we suspect sepsis, or epinephrine for anaphylaxis.
When you're assessing your trauma patient, you need to consider all 4 types of shock, but for the most part, if they've just been in a trauma, they're probably going to be the hypovolemic sort. More specifically, hemorrhagic shock. If they are hemodynamically unstable and shocky, you need to think of a source of bleeding.
Hemorrhagic shock can be divided into 4 severity classes from 1 to 4. To estimate and determine a class, we look at the estimated blood loss, vital signs, capillary refill, urinary output, and GCS. We won't go into the nitty-gritty of this classification, but for more details, check out the ATLS classification of hypovolemic shock. We've attached a handy table in the show notes. A key thing to remember is if your patient is hypotensive, they have probably already lost more than 1.5 liters of blood.
Circle back to the primary survey. The most common cause of shock is by far hemorrhagic shock in trauma. So when assessing our C, we're mostly concerned with finding the source of the bleeding, controlling it if we can, and resuscitating with blood, not pasta water. Definitive bleeding control is essential, along with appropriate replacement of the intravascular volume that they need.
Check the patient's heart rate and blood pressure, their mentation, skin color and temperature, capillary refill, and check for a pulse in all 4 limbs. Next, assess for any potential bleeding and source control. Think of the 5 spots blood can pool in sufficient quantity to kill someone: the chest, the abdomen, the pelvis, the long bones, and the floor.
Oh, ultrasound, you're going to turn the tide. You would have already auscultated the chest. You've felt the abdomen for rigidity or guarding or ecchymosis. That should make you more suspicious for an intra-abdominal bleed, but you're just going to put a probe on and see it anyway. You're going to assess the stability of the pelvis. You're going to do some lateral pressure to see if that causes them pain, and if it shifts under your hands, you don't like that. And then you can place a pelvic binder if you're worried about it. There's commercial pelvic binders available, which are amazing if you have them at the ready. Otherwise, you can just put a sheet or a blanket underneath and tie it tightly around the greater trochanters, not the top of the hips. If you are using a sheet, it's a good idea to tie the ankles together in internal rotation to prevent external rotation of the hips, which can lead to further bleeding.
Palpate the long bones, assessing for any displaced fractures that could be a source of bleeding. Reduce if thought to be contributing to the patient's hemodynamic instability, but don't anchor on distracting injuries. Remember, the primary is designed to find and address life-threatening injuries.
And once you figure there isn't any internal bleeding you need to worry about, you can look for external bleeding. Check the armpits, check the groins, check the scalp. Apply direct pressure to anywhere that is actively bleeding, and you'll probably be able to stop it. A penetrating injury might need placing your fingers inside the injury or providing significant packing. If you can't control the bleeding with pressure, next move is a tourniquet just proximal to the injury. Remember, commercial tourniquet is what is truly required. The improvised just really aren't sufficient often for arterial occlusion. And then you can throw in some quick staples or sutures, but again, this is only for life-threatening bleeds.
As a quick side note, our physical exam is helpful but not great at determining where the blood is. Chest, abdomen, pelvis especially require adjuncts. Get that chest x-ray, fast exam, pelvis x-ray, so we can really know what's going on inside. So you're doing the physical exam is useful and may contribute to your diagnosis, but don't, for example, rule out a pelvic fracture just because it feels stable.
Nice. On the flip side, hemorrhage control, so you want to try and stop the bleeding, is resuscitation. So fill up the bathtub. You want to get 2 large bore IVs in place because you're predicting that you're going to have to fill them up toot sweet. If IV access is not secured, you can consider an IO. Usually proximal tibia and the humeral head are the preferred sites in the grown-ups. The distal femur, in fact, and the proximal tibia and distal tibia are often those used for infants and neonates. So think of traumatic injuries when placing an IO. Ensure the fluids will be able to reach the heart. If you put it past a giant break in the femur down towards their ankle, well, good luck, it's not going to get anywhere.
Depending on their clinical context, trauma patients may require fluid resuscitation. As most shock in trauma cases is hemorrhagic in nature, they specifically require blood. Treating hypotension with crystalloid fluids will not help their shock and has been shown to cause harm partly through dilutional coagulopathies. 1 liter of crystalloids is fine, but if you're requiring more than that, call the blood bank.
Type O packed red cells are indicated for patients with exsanguinating hemorrhage. If you haven't got a type and screen, and often these are going to take a long time, so you will have to give some unmatched. And we do this because we want to avoid sensitization and future complications. Rhesus negative packed red cells are preferred for the females of childbearing age because you don't want to cause them problems in later pregnancies. For the gentlemen, you can often use positive.
In patients with ongoing or suspected ongoing bleeding, give tranexamic acid, TXA.
The medication that's slowly losing its love. Ultimately, if the patient remains hemodynamically unstable even after you've resuscitated, they probably will need OR or IR to get hemostasis.
Some trauma patients may need a large amount of blood products requiring activation of massive hemorrhage protocol. A massive transfusion is typically defined as 10 units of packed red blood cells within a 24-hour period or more than 4 units in 1 hour. It is a good idea to get comfortable with your local MTP to know how much blood product you have access to and how to obtain it.
And the mass transfusion protocol is basically just adding in plasma and platelets along the way because we know that just giving packed red cells has higher mortality associated with it than adding in the other bits and pieces. That being said, to help estimate which patients might need massive transfusion, you can use the ABC score. It's a handy calculator. You can find it on MD Calc if you're in a pinch. The gist of it is, in the ABC score studies, scores less than 2, so 0 or 1, in trauma patients were unlikely to need mass transfusion. Each criteria, which we'll go through now, are worth 1 point. They are:
heart rate greater than or equal to 120 beats per minute,
systolic under 90,
penetrating injury,
or a positive fast scan. They make sense.
If 2 or more criteria are met, your patient may likely require a massive transfusion, so consider ordering the blood to have on hand.
What did your research suggest about using point-of-care ultrasound in the primary care survey?
This is a great question. POCUS is a great tool, especially in trauma cases. The EFAS scan, which can assess for pneumothoraces, hemothoraces, pericardial hemorrhage, and intraperitoneal hemorrhage, can be particularly helpful in our assessment. It is considered an adjunct usually performed following your primary survey as to not distract or delay in identification of life-threatening concerns. It's generally a question of how useful it is. For example, if we have a patient who's totally stable and you have a CT scanner, it won't do anything, so, well, don't do it. If a patient has a gunshot wound to the abdomen is unstable, it also won't change anything. The major pitfall of doing it during the C stage is that it likely takes a few minutes at best and distracts everyone from the more valuable parts of our primary survey.
Love it. That makes perfect sense. So, quick review. While assessing circulation, think of all the forms of shock, but in trauma patients, always think bleed, 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 bleed. Assess for the sources of bleeding in the chest, in the abdomen, in the pelvis, in the long bones, and the external sources, and control them with pressure, tourniquet, staples, pelvic binder, or OR. Get 2 large IVs or IOs if you can't get an IV, and resuscitate with blood. Use your ABC score for potential massive hemorrhage protocol.
Moving on to our D. D stands for disability.
Here, we're assessing their level of consciousness and their gross neurofunction. You're not doing a full coordination and etc., but you'll have a quick look at their pupils during your primary to look for size and responsiveness. You're looking at their overall level of consciousness. This can be assessed using the mnemonic AVPU. Alert, verbal, that is, they respond to verbal stimuli. Pain, responding only to pain or unresponsive. Check the pupils, see if they grossly move all 4 limbs spontaneously, and it can be helpful to use a Glasgow Coma Scale on the primary if you're looking for bad TBIs and spinal cord injuries that could lead to collapse. And we know that Glasgow Motor Scale on its own actually jives pretty well with the full scale, so if you're in a pinch, just do that part.
Until proven otherwise, always presume that changes in level of consciousness are a result of central nervous system injury, brain bleeds. Remember that drug or alcohol intoxication can accompany traumatic brain injury.
And another part of the disability is a quick point of care sugar measurement.
A, B, C, D, E, F, G. Don't ever forget glucose. Hypoglycemia can be contributing to an altered level of consciousness or cause of traumatic event and can be easy thing to address.
Remembering the DEFG has saved me so many times from forgetting about sugars. It's great. All right, we're at E. This is exposure and environment.
Let's completely expose the patient to assess them from head to toe for any bodily injury. Again, armpits, groins, and scalps tend to be areas where injuries are commonly missed. Check everywhere. Importantly, this includes doing a log roll to examine the back for any injuries, palpate the spine for any tenderness, or step off deformities.
Ensure you maintain spinal motion restriction during this. You'll need multiple people, and the log roll can be an opportune time to get a DRE to look for bleeds from the anus and anal tone if it's appropriate. They're certainly not necessary in every trauma patient, but if you think they might have distal bowel injury, spinal cord injury, or a rectal injury, then do the DRE.
Remember that they're already going through a pretty stressful situation, so make sure the information you gather from the DRE is worth it. If the patient can follow commands, you may also opt to simply ask if they can squeeze their glutes together.
Love it. And also at this time, if you're going to check core temp and take appropriate measures to prevent hypothermia, this is the time to do it because you have access to a rectal temp. That brings us to Objective 6. In trauma patients, rule out hypothermia on arrival and subsequently.
Hypothermia, typically defined as a core temperature below 35 degrees Celsius, can be caused by an increased heat loss due to exposure to a cold environment or impaired regulation due to brain injury. In trauma patients, always consider shock as a potential cause. When you're systematically shut down, you don't make that much heat.
And then it's a bit less likely in trauma cases, but hypothermia can also be caused by decreased heat production because of something like hypopit or hypoadrenalism, hypothyroidism.
So how do we recognize hypothermia?
All your trauma patients should have a core temp. So that might be rectal, or if you put in a urinary catheter, have it done with a temperature probe in it. In cases of mild hypothermia, so anywhere from kind of 32 to 35, they might be tachypnic, tachycardic, they might be shivering still, and they might have some ataxia and dysarthria.
When hypothermia becomes moderate, so 28 to 32 range, patients can lose their ability to shiver, have a decreased level of consciousness, can be combative, and muscle rigidity starts to set in and dilate their pupils.
And if it's severe, that's less than 28 Celsius, they might have things like hypotension, acidemia, they might go into VFib very easily, asystole, they could have flaccidity, apnea, or even coma.
Especially following full exposure, trauma patients are at increased risk of developing hypothermia. It is important to frequently check in on the patient's temperature and take appropriate measures to prevent it. These include keeping the patient warm with blankets, using warm fluids during resuscitation, and considering heaters, like those bear huggers, if necessary. Remember, hypothermia is part of the trauma triad of death, with acidosis and coagulopathy, a combination that results in significant rise in mortality rate.
Oh, believe it or not, we're done. Primary survey. It's actually going to take you 32 seconds in the recess bay, but we did it in 42 minutes or wherever we're at.
That's it?
Yep, it was a ton. The primary survey can be complex. It can be daunting, but remember, we want to identify life-threatening injuries and act on them now. If there's a sudden deterioration in the patient, despite a previous primary survey that was reassuring, start again from the top.
Let's quickly recap our primary for you guys.
A is airway and C-spine protection. Secure a patent and protected airway and ensure they have a collar on if it's indicated.
B for breathing. Look at the resp rate, oxygen saturation, and signs of respiratory distress. Listen for the bilateral air entry. Feel your chest wall for any injuries and address life-threatening findings. This could include oxygen, needle decompression, or chest tubes.
C for circulation. Look for shock. Think bleed, bleed, bleed in the trauma patients. Assess for the shock, find sources, control them if possible, and resuscitate with blood and blood products.
D for disability. Assess those pupils and gross neurological function with AVPU. Consider GCS as well. Any altered level of consciousness, suspect a TBI, and don't ever forget that glucose.
E, exposure and environment. Fully expose the patient. Log roll them in the armpits and the scalp and all those hidden areas in the groin, and look for spinal injury and involvement. Check their temperature and treat hypothermia if it's present.
Important note, you can and should do a good primary survey in less than a minute. It is an important skill to quickly rule out things that are potentially trying to kill your patient.
And we are merciful, so we're going to try and trim this one off. We'll do a part 2 for the remainder of the objectives that you need to know for trauma for the CCFP. Thanks guys for listening, and listening for part 2. Bye-bye.